The lower leg consists of the area from the knee down to the ankle joint. The ankle joint is composed of the distal tibia and the talus. Let's start with our lower leg fractures. In athletic activities, lower leg fractures occur to the tibia and fibula. The tibia is a weight-bearing bone, whereas the fibula is not. Therefore, stresses from the foot contacting the ground can cause overuse tibial stress fractures. So we can have both acute as well as overuse stress fractures to the lower leg. These acute fractures may occur to only one or both of the bones simultaneously. The fractures can occur anywhere on the bone, but the tibial shaft, usually the distal third of the tibial shaft, is most commonly fractured. When we look at mechanism of injury for lower leg fractures, we need to separate them between overuse and acute. So when we look at overuse or stress fractures, these occur due to constant repetitive bounding of the foot on the ground. Stress fractures can occur when an athlete is poorly conditioned, has increased the intensity or changed her activity or his activity too quickly, or wears shoes that are inappropriate for the activity. For acute fractures, these are caused by a fall, motor vehicle accident, a direct blow to the bone, or a twist to the lower extremity. Signs and symptoms for an overuse type of injury. So for stress fractures, we will have gradual onset of localized tibial pain. This pain increases during activity and decreases at rest. They may have point tenderness, and the athlete may walk with a limp. For acute lower leg fractures, the athlete feels pain and is unable to move the body part. There is point tenderness, and they may also exhibit swelling, bruising, and deformity in the area. These also may be open in nature, so we need to make sure that if there is any bleeding in the area that we do clean it, but these could be open like the femoral fractures that we talked about in the last section. For treatment of the acute type of leg fracture, we need to call 911 and treat the athlete for shock. Again, if it is an open fracture, we need to control the bleeding and carefully dress and bandage without moving the leg. Splint the extremity in the position that we find it. Apply ice and monitor their ABCs and for shock until EMS gets there. For a stress fracture, we need to make sure that we stop all weight-bearing activities until they are seen by a physician. So what we can do is we can fit them for crutches or put them in a walking boot. But we also want to make sure that we use ice intermittently to decrease the pain throughout the day and take anti-inflammatories to help with the pain and inflammation. To prevent acute fractures, we should wear protective equipment such as shin guards in soccer. For stress fractures, they can be prevented by strengthening and stretching lower leg muscles, using proper biomechanics during activity, wearing proper footwear, and gradually increasing intensity, duration, and type of training. Our next injury is medial tibial stress syndrome, also occurring to the tibia. When we look at medial tibial stress syndrome, this is an overuse injury and is commonly called shin splints. Medial tibial stress syndrome affects the overlying tibial muscles, of which the posterior tibialis is the most commonly affected. When we see this, if we don't treat MTSS or shin splints, it can progress into a tibial stress fracture. For a mechanism, it's caused by an overload of the medial musculature that lies over the tibia. The overload occurs when the athlete increases intensity and duration of activity too quickly, runs on uneven, slanted, or hard surfaces, runs downhill consistently, and performs activities that require sudden stops and starts. Signs and symptoms: athlete has pain and point tenderness on the middle portion of the tibia towards the lateral or distal third of the tibia, and they may have some myodiffusion. When we look at this type of injury, we want to make sure that we apply ice and take NSAIDs to help decrease pain and inflammation, and limit the athlete's activities that cause the inflammation. So kind of like treating it for a stress fracture of the tibia, we're going to do the same type of treatment for medial tibial stress syndrome. To prevent this, we want to make sure that the lower leg anterior musculature is strengthened and stretch the posterior musculature. We also need to wear properly fitted shoes with arch supports. And if they don't have arch supports, maybe we could tape or provide arch supports for that individual with orthotics. Compartment syndrome can also occur in athletics. And when we look at the compartments of the lower leg has 4 compartments that contain muscles which move the ankle and the foot, along with nerves and blood vessels. And compartment syndrome is a condition in which the pressure in the lower leg compartment increases and begins to compromise the nerves and vascular structure. So it really cuts off all that blood supply and feeling down into the lower leg. We have 2 different types of compartment syndrome with a little bit different mechanisms. For acute compartment syndrome, it is a very limb-threatening injury, and we see that this is caused by a direct blow or severe trauma to the lower leg, such as a tibial fracture. They can also get hit or kicked into the leg that can cause an acute compartment syndrome. For exertional compartment syndrome, this mechanism or this type of compartment syndrome occurs during exercise and activity that's chronic in nature, and this is typically caused by muscular contraction during activity or exercise. And when a person has increased amount of exercise activity, there's excessive pressure that builds up in the compartment, and it has no way to decrease that pressure during activity, so it continues to build and build and build in that area. When they look at signs and symptoms for acute compartment syndrome, they have persistent pain that develops over hours and progressively gets more intense and more intense. They have swelling, redness, and decreased sensation into the lower leg and foot area. For exertional compartment syndrome, they also feel pain that comes on gradually during exercise, but continues to increase until exercise is stopped. They also may feel a loss of sensation and muscular weakness. There's a little bit different treatment for acute and exertional. Acute compartment syndrome is a medical emergency, so we need to call 911. When we do call 911, the athlete typically requires surgery to treat this, so we want to make sure that we monitor them as EMS gets there and get them to a hospital as soon as possible. For exertional compartment syndrome, it's not a medical emergency, so the athlete should stretch that area where orthotics, make biomechanical changes in their running or walking, and rest from activities when they need to. When we look at acute compartment syndrome for prevention, we want to make sure that we wear protective shin guards in activities that are deemed necessary. And for exertional, it's really not preventable in any sort of way, so it's hard to prevent exertional compartment syndrome. We could also have strains to the lower leg. The gastrocnemius and the Achilles tendon are commonly strained. And the Achilles tendon is prone to ruptures, typically in their men in their 40s. And when we look at these types of strains, we do see the Achilles tendon having more problems than the gastrocnemius. The cause of a lower leg muscular strain are a forceful muscle contraction or a sudden stretch. And we can also see repetitive loading that can also cause these strains to occur. We look at signs and symptoms. They're a little different between grade 1 and grade 2 and grade 3. When we look at grade 1 and grade 2, we usually see the typical signs and symptoms of a normal strain that we talked about in the rest of the body. So we have pain, point tenderness, and the like. For grade 3, we typically hear a snap or a pop at the time of the injury, and the muscle rolls up. It creates a bulge in the calf area. When we also have an Achilles tendon injury and we squeeze the calf muscle, that foot will not go into a plantar flex position as we typically would see with an intact Achilles tendon. Just a few pictures here. We can see where a strained Achilles tendon is, And we can see that grade 1, 2, and 3 different strains in that left-hand side picture. For the gastrocnemius, this is referred to as a calf in this picture, but it can occur to the short head or long head of the calf muscle, and they usually occur proximally or closer to the back of the knee. For treatment, we want to make sure we use the Rice principle and put the individual on crutches if they needed to ambulate, and then refer them to a physician. For grade 3, we want to make sure that we treat them for shock if they go into shock, call EMS if needed, but we want to make sure we get them to a physician or the emergency department to get them surgically repaired. In order to prevent strains to the lower extremity, or the lower leg, we want to make sure we get them into a lower leg flexibility program and strengthen the anterior muscles. We can also have tendinitis that can occur in the lower leg, ankle, or foot tendons. The Achilles, peroneal, and posterior and anterior tibialis tendons are commonly affected by inflammation, and this type of tendinitis can be acute or chronic. When we look at tendinitis, it's typically caused by a quick stretch or contraction if it's acute tendinitis. For chronic, it's caused by repetitive loading of the tendon. Now, the tendon can also become inflamed due to continued friction against an object, such as the back of a shoe, improper lower extremity alignment, or faulty biomechanics during activity. Signs and symptoms include pain, possibly crepitus or that crunching sensation with activity, point tenderness, and mild swelling. We do want to use the Rice theory on tendinitis, apply rest, ice, take anti-inflammatories, and correct or stop any types of movements that cause stress on that tendon and cause that pain to occur. To prevent tendinitis, we want to stretch, use proper technique, complete the proper warm up and cool down before and after activities, and avoid activities that place undue stress on the tendons. Ankle dislocations are very traumatic for an athlete. When we look at ankle dislocations, they are very similar to knee dislocations, just in a different area of the body. The ankle has a pretty good amount of mobility, but also has a great amount of stability between the talus and the tibia, especially when we're in a dorsiflex position where those bones are really close together. Therefore, there has to be a great amount of trauma that we need to have that can cause an athlete to dislocate their ankle. Ankle dislocations are also typically occur or also have an associated fracture with them. When we look at specific mechanisms, remember we need a severe force. We need to place that severe force or extreme force onto the joint. The severe force can be from a direct contact, high intensity collision, fall from a height, or motor vehicle accident. And really what happens is that an athlete can really push their ankle beyond the area of movement. Signs and symptoms are very similar to a knee dislocation. We have severe pain. Typically, the athlete is in shock. There is deformity, swelling, point tenderness, and abnormal or loss of sensation in the affected limb's toes. And the athlete cannot move that joint. For immediate care, we want to make sure that we call 911, treat the athlete for shock, and stabilize and split the athlete's ankle in the position that we find it. After we do splint it, we can provide ice over the area and monitor the athlete until EMS arrives. Again, like knee dislocations, there's nothing that we could do for an ankle dislocation. We can help by making sure that our musculature around the ankle is strong. Last but not least, we have an ankle sprain. Ankle sprains are your run-of-the-mill common ankle injuries that we see on an almost day-to-day basis in athletic training. This is the most common lower extremity injury and occurs to the lateral medial and anterior tibiofibular ligaments and the syndesmosis. When we look at mechanisms, We can have ankle sprains that occur when the joint is forced beyond its normal range of motion. On the lateral side, it's caused by excessive ankle plantar flexion and inversion. On the medial side, it is caused by forceful ankle dorsiflexion eversion. And for a syndesmotic or high ankle sprain, it's caused by forceful dorsiflexion, typically from landing from a height with the ankle in full dorsiflexion, and that tibia comes down and jams into that ankle joint. Sinus symptoms will present with pain and point tenderness at the site of injury. So depending on what ligament is injured is where the pain is going to be. Swelling, ecchymosis, redness, joint instability, and loss of function are also present. So for treatment for an ankle sprain, immediate care includes RICE. If they do have severe limp or ambulatory problems, we can fit them for crutches, especially if they cannot bear weight on that area. If the athlete needs crutches or has pain in a certain bony areas that you're concerned with, we can refer them to a physician for further evaluation, because it may not just be an ankle sprain, it may be a fracture or some sort of other injury that we cannot see from the outside. For prevention, we're going to make sure that we have proper range of motion around the gastrocnemius and Achilles tendon, strengthen the muscles around the ankle, and make sure that we have good lower body coordination, balance, and agility, and make sure that we're wearing proper shoes for the activities that we are participating in.